Okay, it's 12:30, so I think we better make a start. First off, welcome everyone. Thank you for attending today's webinar on migration and healthy aging. Before I hand over to our presenters for today, I'm just going to give a brief intro and just go through one or two of the rules for today. First off, my name's Tom Carter. I'm the Junior Coordinator for the European Forum for Primary Care. For today's session, if I could ask just during the session that we have all webcams off and microphones muted. This is just to avoid any sort of background noise or connection issues. During the presentations, if you have any questions at all, feel free to put them in the chat box, as well as comments. Any discussions as well will be encouraged. The session will be recorded, as well as the chat box too, so we'll keep a record of that for you. If you wish to speak during the presentation or during the session when we discuss questions, please unmute yourself so you indicate that you want to say something. What I'll also do as well is I'll collate all the questions in the chat box that people put in during the presentations, and after the presentations are finished, I'll put these up on a slide so our hosts can have given opportunity to answer the questions you've asked and hopefully have a discussion. Furthermore, we do, obviously this webinar is based on our working group that the EFPC currently has on mental health. So the points you see on the slide here are just some of the questions that we seek to answer during these working groups. But of course, from our side of the EFPC, we'd love for you to get involved, and if you know any colleagues that would like to get involved, so please let us know. We're always looking for more input, more information, and it'll be great to have good connections and resources. So what I'll do is hand over to our host. So first of all, Kathy Moon from the Norwegian Research Centre, and Frode Jacobsen from the Centre for Care Research of Norway. So I believe Kathy's starting, so I'll hand over to you.
Thank you, Tom. My name is Kathy Moen, and I am a medical doctor and a researcher here in Norway. Today we are going to discuss about migration and healthy aging. My colleague Frode will talk about perspective from service providers, while I would like to talk about what is healthy aging and how migrants are from a migrant perspective. So let me share my presentation here. Okay. So elderly migrants and healthy aging, that is the topic for today. So what is aging? Aging in World Health Organization published a report in 2015 where they say, just a minute, where they say, just a minute, Tom, I don't see the whole screen. Why is that? Is there any way we can take away this picture on the right corner?
How do you mean? Sorry, because you're sharing the you're presenting at the moment, the whole slide.
Yes, it says go to meeting. People can see your screen.
Yeah.
But I don't see the whole screen, the whole of my presentation, but I'll manage. Okay.
Maximize the window on your own screen. That also is a possibility. If you just enlarge it on your own screen, then it's yeah, it's easier for you to use, I guess.
Yeah. Okay. Yeah. So the World Health Organization published a report in 2015 where they say from 2000 So people over 60 years set to double by 2050, from 12% now to 22%. So it's a double amount, 12 to almost 24%. So it's a major challenge for the countries, how we are going to give them the good health system, and how it will affect the society. People live longer now, but is it not necessarily healthy lives? So there are low-income countries and high-income countries, and the aging in high-income countries and low-income countries will be very different process. And there will be differences in social determinants of health between groups in a country, between migrants and the natives, and among migrant groups also there will be a huge difference in aging. So that we should have in mind. So to face this increasing number of older people, governments should develop health systems and social systems which would be ready in 2050 to help these aging groups. Let's go to the next slide now. Here you see the rich elderly and the poor elderly, how the gap is. There is a vast gap in high-income countries, how people get older, and in poor, low-income countries where the elderly have no place to live and no one to take care of. So what is healthy aging? If we see this slide, World Health Organization describes healthy aging as the process of developing and maintaining the functional ability that enables well-being in older age. So aging is a long time span, you see, because when you are young and can work, then you maintain the ability to work. That is very important. And the maintenance of health, prevention of disease, you should take care of. And prevention of disease is not the same in all countries. I mean, high-income countries and low-income countries. For example, in high-income countries, you have these screening programs for cervical cancer screening and colon screening and so on. And people, if you are a GP in a high-income countries, you know that people come for just to take a blood test, whether to check everything is okay. But not in low-income countries. There, people go to doctor if they have some symptoms. And after you retire from your work, the management of chronic disease and multi-morbidity and multiple medication is a challenge. So timely diagnosis and compliance to treatment and continuity of care is vital in that age. And the interaction with healthcare services and social support networks is also important when you have multimorbidity. And after after 70 or 80 years old, then cognitive decline is also a problem, and palliative care when you become very ill. So all these factors we talk about includes in aging as a long time span. And aging process vary as we talked about across different populations and different countries. Aging is also influenced by many factors like genetic factors, that if your parents are sick with a genetical disease and then you get that disease. And physical and social environment as social determinants we talked about, where you live, the environment you live and grow, and the economy you have in that country, a neighborhood, education, and the health, what type of health care you have in that country. These are the social determinants of health. And personal characters, of course, that you take your health seriously and exercise and eat nutritional food. These are also factors that influence your health and aging. For some reason, Tom, I don't. This doesn't work when I click down the next slide. So I don't know why. So migrants and healthy aging. So how aging influence migrants? As many of you all know, migration itself as a social determinant of health. The other social determinants we discuss now: economy, neighborhood and environment, education, what kind of job you have, and healthcare. But migration itself also a social determinant of health, because before you migrate, you face some challenges in your own country. Your country may give you a good healthcare or not necessarily a good healthcare like prevention of diseases. So during your migration, what kind of health services you get? It could be a strabaceous journey that takes months from your home country to the host country. So during that period, it can be possible that health deteriorates. After migration, what type of healthcare refugees and asylum seekers get in the new country is also very important. And to navigate in this health system in the host country and find help is a big challenge for many migrants. And migration status and age. When you are a migrant, so studies show that both your status as migrant and your older age are predictors of unequal access to healthcare services. Studies showed in Norway that older migrants seek rarely help when they ill to their GPs, lower than their counterparts, the Norwegian elderly. And there are also, in addition, migrant-specific risk factors we shall see in the next slide in healthy aging, how that influences healthy aging. Migration-specific risk factors is listed as you see in this slide. Exposure to health risks before and during migration. I talked about that already. a more disadvantaged socioeconomic position. When you are a migrant, you come to a new country and you have to find out all the things by yourself. Sometimes you get help and sometimes you don't. And migrants overlap with socioeconomically disadvantaged aging people in the native populations also. But that's not what we are going to talk about here. Here we'll talk about migration-specific risk factors, how a migrant undergoes these factors in the host country. And when you arrive in the host country, you don't get a job right away. You have to be in the detention camps, or you take so long time to find things, how you can learn the language and how you can get a job. So during that time, you maybe the migrants don't prioritize their health, and having a lower economic position doesn't help either when you want to seek a doctor. And language barriers and low health literacy is a very important thing, because when you don't speak the language in the host country, then which is a key to the health system in the host country, then you are always at the back in the queue. Low health literacy about screening and prevention of diseases and the symptoms and the symptoms you get when you get ill. If you don't know why I get these symptoms, then you just postpone your visit to your doctor. And of course, cultural factors influencing health-seeking behaviors. When I had this research about cervical cancer screening among immigrant women, bleeding as a symptom was not taken seriously to go to the doctor. So they don't go to the doctor if they don't get symptoms. So screening behaviors and prevention knowledge about prevention of diseases have been low among some groups of migrants. And when you are a migrant, psychosocial vulnerability and discrimination affecting health and quality of life is also a problem. So as you see here, aging and migration is a very complex and multidimensional process, and it's shaped by a range of factors that we discussed now. So there's a complex interplay between cultural factors and dietary practices, physical activity patterns, and socio-economical background, how you live your residential area, and language competency. All these factors play a role in the healthy aging as a migrant. So we can just discuss a little about migrants' access to healthcare. When you have this language barrier and lower health literacy and the lack of social networks that facilitate access to timely care, there are many challenges there, because maybe when you are a migrant and old, you may have an extended family to take care of, and even though you have many people that surround you, your children, grandchildren, relatives, may not help when you get ill because of the language and health literacy barriers. So social networks in your community is very important. That community social networks takes care of the elderly. And of course, the insecurity related to intercultural encounters between patients and health providers. In a research about cervical cancer screening, we talked with the GPs. What are the barriers to take the gynecological test? So they told us were many factors, but especially that immigrant women don't come to them and don't make specific appointments to take cervical screening tests, and lower knowledge of cervical screening were some barriers which they mentioned. And of course, when they come to GPs, they have so many things to discuss. So this prevention and screening always comes in the end, and not to be taken as seriously. But the immigrant women told us that the GPs don't ask them about these things, and they don't explain about cervical screening and other health services that exist in Norway. So I would like to conclude that countries should focus on policy approaches when it comes to healthy aging among migrants. Migrants should be acknowledged and incorporated into healthy aging policies, and needs of aging migrants should be taken into account, and not only the needs, but specific needs of aging migrants, like process of migration, cultural values, their cultural values, and language barriers is also should be taken into account. And awareness raising at all institutional levels, for example, cultural sensitivity training among healthcare staff, and strategies for overcoming informal barriers in service delivery should be taken into account. When we talk about integrated, diversity sensitive, interdisciplinary care, I mean that when you hear integrated healthcare, that is promotion of health involves variety of factors. You don't see just the symptom, you see the whole person, such as psychology, the person's psychological, biological, social, communal and economics factors which surround the person. Especially the elderly needs integrated care. And when I talk about diversity sensitive care, you can give health services in two ways. You can give migrant sensitive or migrant specific. But some countries, for example, Denmark, have established these migrant clinics at the hospitals. So even though you give the same care for everybody, both the natives and migrants, some migrant groups have specific needs in some diseases. For example, people from Sri Lanka, Pakistan and Bangladesh, they get heart diseases in an early age, and they have this abdominal fat which can lead to so many other lifestyle diseases. So in that context, that you give special care for these people, that is migrant specific and migrant-sensitive care. And when you give healthcare to the elderly, interdisciplinary care is very important. You see at the nursing homes that you work with the doctor and physiotherapist and the nurses. So everybody should come together and give the healthcare that the individual need. That is interdisciplinary care. So that's what I have today. So I'm sorry if I used some more minutes over. Thank you.
Thank you very much, Kathy. And no problem with the time. No problem at all. What I'll do, we do have one or two questions already, but Kathy and Frodo, it's up to you if you want to maybe address one or two now, or if you'd like to, if we'd wait for Frodo to give his presentation and then we can follow on from there. Yeah, if that seems to be the better option. Okay, no problem. Yeah, what I will do is pass over to Frodo then. Thank you very much, Kathy.
Thank you.
Yeah, hello. I think now it's functioning. So I'm Frode Jacobsen, also from Bergen. I'm a research leader of a Center for Care Research, as a multidisciplinary research center in a national structure where we are altogether 4 centers for care research located at different universities. I can't see the whole screen, but I will try to guess what I can't see. And anyhow, the background for my center's research interest in the topic of diversity of the staff is that we detected that yes, there is a growing literature in Norway where the focus is on older service users or residents or patients in the long-term care and how they fare in the services. But they still constitute a relatively small percentage in our country, in a stark contrast to, for example, the Netherlands. While Kathy, you dealt mainly with this group, I would try to go on and also try to speak about why could it also be interesting to look at some of the same things you mentioned, Kathy, with regard to older migrants, the need for being diversity sensitive and the needs for addressing inequalities and vulnerability. Also in the carers, among the carers, the immigrant members of the caring community. So we detected that there was almost been no research on the immigrant staff, at least in our country. I think the situation is better in for example, Great Britain and the Netherlands and some other European countries. But we detected that they constitute quite a significant proportion of the workforce in long-term care. As one example, in our town, one nursing home had 30 nationalities in the immigrant population of workers, and slightly more than half of the staff had immigrant background. Yeah, we also saw such examples in other parts of Norway. And we realized that we know way too little about what are the consequences of this. how do the migrant workers, immigrant workers experience their work conditions? How are their participation making a difference to the services from various actors' perspective? We wanted to really look into that. The plan for this talk briefly is to take as a point of entrance the increasingly multicultural staff in the long-term services. I will try to say just something briefly on the general work migration trends with a focus on long-term care, challenges for workers in the long-term care, and go a little bit into a recent Norwegian project we are heading in our center, looking at both the challenges but also possible benefits and opportunities. And by conclusion, pay particular attention or to ask the question, why pay particular attention to migrants in the long-term care services? So globally, life expectancy together with multimorbidity and chronic diseases are increasing, and this combined with a drop in fertility, fortunately more and more women joining the workforce, and also increasing divorce rate, all contribute to a demand for care and hence for healthcare personnel. And to meet this demand, workers from abroad are increasingly hired, not only in our country, but it looks like across European countries and North America, for example. So increasingly, the workforce in health and care services provision for the elderly in Norway in the EU are migrants. So we could ask the question, what could be the possible benefits and challenges to a steadily more related to a more steadily more multicultural workforce in service provision? So the number of individuals migrating across border has increased hugely in the past 40 years. More than half of them moving from so-called developing to so-called developed countries. There are presently, it's not brand new stats, but anyhow, around 150 million migrant workers worldwide. More than half work in the service sector. And quite many of them working in health and care services. Nearly 10% are employed as domestic workers. The number of migrant nurses and doctors immigrating from countries with severe shortages to countries like ours has been increasing from 2000 to 2010, as an example, by 80%, which is really staggering. The working situation for migrant and minority workers is characterized by temporary and part-time jobs. And in addition, the migrant and minority workers are overrepresented in the less skilled occupations. Migrant and minority workers are also at high risk of, and I can't see some important part of the screen, sorry for that. They have an increased risk of layoff and also face exploitation in various ways. The risk of also injuries, both fatal and non-fatal, is higher for migrant and minority workers than for the majority population. There are different types of work engagement in care work for older people. You have, as already mentioned, live-in foreign home care workers, that might be the most vulnerable in many ways. And you have immigrant workers in the formal care services, either home-based or institution-based, like, for example, nursing homes. Regarding challenges for immigrants caring for older people, firstly, there is this stereotype that has been much documented, for example, in Great Britain, but we find them also in other countries, including our own, where migrant workers from the so-called global south are perceived as inherently caring and like natural born carers for example, frail older people. And hence we could expect from them harder work, flexible work hours, lower pay, and working public holidays. Lower pay is not the case so much in our countries, where, for example, the hospital sector and the municipal care sector, for example, the nursing homes, the pay differences aren't that different, and the pay difference between different occupational groups are lower than in many other countries. But anyhow, the three others, not the least flexible working hours, expected to work on public holidays, are real challenges, as we also have documented among the immigrant care staff. So you find discrimination based on so-called positive stereotypes, of course not positive, both in Norway and internationally, but of course with much variation. So you also find occupational downgrading, which is documented from, for example, I have a reference from Sweden, but it's documented many places in Europe. And you also have discrimination, injuries, and health, and also the health is affected from that. So migrant and minority nurses, for example, are at high risk of work-related injuries and more, and from discrimination more than the majority population. Migrants and non-native groups experience poor health outcomes or poorer outcomes, for example, when it has to do with accidents and disabilities than so-called natives. Home care and migrant staff vulnerability seem to be related to so-called three axes of vulnerability: the intimate nature of the job, the gender nature of care work, migratory status, in particular, if temporary. Before concluding or summing up, I just wanted to tell you a little bit about some preliminary findings from a project we are still running, and as you know, publication is a slow matter, so most of the things we publish after the project ended. But anyhow, we have some publication, and I just mentioned a few of them. Just as a starter, around 90% of institutional care providers with immigrant status in Norway, it's not brand new stats, but as it was in 2017, it's not possibly not very different now. In our project, we found a mixed, we had mixed findings. I mean, some of them more positive, some of them not positive at all. Just as one example, we found that in some institutions we researched, where we also took part with participant observation and different forms of interviews, we saw that competence seemed to be stressed much more than ethnicity, skin color, and so on. The other side of the coin that some of us are focusing, we could call a kind of color blindness. We have a comparative part of this taking place in the Netherlands, where people much more explicitly talk about, it seems to us, in long-term care, about cultural differences and are more open about them, which I think is positive. But anyhow, it's two sides of this coin, where there might be a certain type of color blindness, where people behave as if there are no cultural differences at all. Another researcher on the project, she's soon to defend her thesis, has also documented discrimination based on ethnicity, mother tongue, and/or skin color, more from residents and their close family than from the majority staff, but still feeling harassed about it. At the more general level, organizational condition, incomplete training, and attitudes of so-called willful ignorance seem to maintain, also in our country, immigrant trajectories to support a new immigrant each at the lower tier of the long-term care sector. I won't go into details, but just mention as one example, we have tried in 2 institutions to document also the how big percentage migrant workers have and their spouses, and we found and that's disturbing thing. We found that also their partners seem to have low position. The mostly immigrant partners seem to also have a low employment position, so that they might, even in our society, live in relatively poverty. We have examples of inclusive leadership that can counteract ethnic pyramids in individual nursing homes at a lower level. In one study, the informants shared largely positive experiences, stating that the care services are valued and that caring provides them with a sense of mastery. And also they talk about trustful relationships and almost becoming like family members of the residents or patients. I won't go into detail, but just as one example, we found that older people who had experienced wartime in wartime occupied Norway could find similar experiences in younger immigrant staff who had experienced war, refugee status, and so on from their home countries. So sometimes I mean, this diversity led to establishing quite close bonds between some immigrant workers and majority older people as care recipients. So anyhow, and that leads to my very final slide. Why pay particular attention to immigrant workers in the long-term care? Firstly, I would think because they constitute an increasing share of the total staff. Secondly, they constitute an increasingly diverse staff might better serve an increasingly diverse population of older service users. So the wartime war experience is just one of many examples one could think of where people could share experiences in a meaningful way across cultural and ethnic boundaries. Thirdly, staff working conditions influence, it seems like from many studies, quality of care. So there is a relationship between how is the situation for the carers and how is the situation for the ones cared for. So it seems like, for example, staff characteristics are related to quality of care in nursing homes, and staff working conditions, both in hospitals and nursing homes, is relates to how service users or patients fare. Thank you.
Excellent. Thank you very much, Frode. And again to Kathy as well, to the both of you for those presentations. I'm a little bit wary, of course, of the time. We only, of course, have about 15 minutes left, so a bit of time left for discussion. What I'll do, just quickly, I'll share my screen, obviously, given some of the most common questions that have been asked already. I see in the chat box there's been a bit of discussion, particularly in the case of sort of coordination of providing support for care professionals who from a migrant background, and also for patients as well. If you just hold one moment there, I'll put it up for you. There we go. Yeah, you should be able to see it now. So first of all, Kathy and Frode, I mean, I know there's been a bit of discussion in the chat box, but the first question really was how could decision makers, users, and oh, sorry, my apologies, that's the wrong slide. There we go. Sorry. So if you have no social network and you have low health literacy, there should be sort of a different approach. So primary care can be outreaching to these sorts of patients. But the issue is how this should be tackled. So is it more the responsibility of the provider themselves, the GPs, or is it a shared responsibility, and who should be involved? I know that in the discussion box here that Mairead has mentioned, obviously in the UK there are things such as advocacy services and charities that can support it. But I was wondering, actually, Frode and Kathy, if you know of any of these sorts of things in Norway or elsewhere in Europe, if there are similar sorts of strategies, really.
I can answer for Norway here, because in Norway everybody has a GP. Mm-hmm. If you live in Norway for 6 months and then you get a GP, so that will be the GP's responsibility to introduce his or her patient for all these health services that which are available in Norway, whether you are poor or low health literacy or good health literacy. That's a GP's responsibility, I would think, as a GP. But so the question is, if you don't have a family around you and you are alone, right? I understand that you don't have a family network around you to support. Then the welfare services that take care of this person, and of course the GP when it comes to healthcare services and coordinating the health around this patient. Yeah. I don't know whether Frode would like to say something more.
Yeah, no, I will primarily subscribe to what you say, Kathy, and I also think that relates to the second question also, that also more professionals probably should be involved. We have some not very new any longer, but some experience with the primary healthcare teams in our country. So one could perhaps think of ways of expanding, so that but that would of course need a proper coordination. So that's also a present discussion in our country, how to coordinate such teams.
Yes, I agree. In a primary healthcare team, there's a GP. We suggest that lead the coordinational care around the patient, and I know that many countries, other countries, have primary healthcare teams where the GP is a leader, but in Norway we are going. I think we'll take it into account further these coming years, where the GP works together with the other healthcare providers around this patient.
There are some interesting interesting experiments in, for example, in Manitoba in Canada. We work a little bit together with them, and they also have such teams where also social workers, occupational therapists, and many other groups are involved. So they are they are quite multidisciplinary. But anyhow, it's still relatively new in our country, isn't it, Kathy?
Yeah, there are challenges that the GP and the other workers like physiotherapist and what do you say, ergotherapist, Frode? That is
occupational therapists.
Occupational therapists. They face some challenges when they work together. Who should lead it, and who can more about this subject? And there are challenges I heard from colleagues from Belgium, I think, in a conference. But mostly it was popular among patients, and it should be the way we go further in the future, I think.
Yeah.
Maybe I can introduce myself. My name is Kim Roos, and I am an occupational therapist. And I'm from Switzerland, and in Switzerland we unfortunately don't have the system of GPs, but we have social centers. So, for example, people who have less support can spend their leisure time in the social centers, and in the social centers there are also social workers or occupational therapists, and if they recognize somehow health problems, they can make the connections. And in my experience, it is very important to have or to build up a relationship to these migrants, and they will never go themselves to the healthcare system, but if they have a relationship and if they have a support, then they will get this help. So I think it's there's a gap between the society and the healthcare system which need to be filled, and it can be filled through something like, for example, this social projects or meeting points or whatever. Yeah, community-based meeting points. Yes.
Yes, I agree with you. In this, we need a participatory approach to this, I think, where you involve intercultural trained staff, and you recruit ethnic minority staffs or volunteers who can help migrants, and lay health workers in Norway at the hospitals and gynecological sectors. There we have this we call bydelsmødre. That means that women who have given birth and from the same community help the women who are who are giving birth at the hospital. So that was very popular, and they were enhancing that system to other regions also in Norway.
Yes, that sounds interesting.
Yeah,
and we go to, yeah, there's another question here, Frode, the number 3.
Yeah. Would you start to say something about that, the health records of migrants, Kathy?
Yes. You are entitled to a GP if you are a migrant or asylum seeker or so on, if you live in Norway for 6 months. So when you are entitled to a GP, you go to the GP, and the GP have all your health records. But the practical problem is many migrants don't know that they are entitled to a GP. We have these health centers driven by Red Cross, Norwegian Red Cross, who undocumented migrants come there. And sometimes I experience people who are entitled to a GP also come to these centers. They didn't know that they can have a GP, or they did not know how they get access to a GP. So even though the law says something, in practice, the migrant don't get the service. So there is a gap between these two things. So we should do something about that. Inform the migrant when they arrive that they are entitled to a GP after 6 months and so on. And the question is, how does the variability of available data impact the health of elderly migrants? I don't understand the question properly. I think the person asked that the variability of available data, that is available health services maybe.
Yeah, Kathy, actually was from myself. I was just thinking, I mean, I know that when migrants, often, especially the elderly, they come to another country, their existing health records from the country they've come from often varies a lot. So whether it's comprehensive enough or if there is any existing record, it's more just, I thought, well, it's an interesting point to think of how this might impact their care once they arrive in the country that they're migrating to. So, for example, if they have existing conditions already, which they've been treated for, and it might not necessarily be to the knowledge of the GP they see. So it might be that the GP doesn't know what kind of care they've already received and things like that.
Yes, I agree, Tom. That is a big challenge in these health centers driven by Red Cross, because when a migrant, undocumented migrant come to us, we don't know, they come with these boxes of medications which were prescribed in their home country, and we have to start from the scratch. Does this person have high blood pressure, and what type of medications that were given? We don't have any data which we could get from the home country or other countries where the migrant was detained before. So that is a great challenge. Often we start from the scratch. If it's different sickness, we take blood pressure, blood tests, and all the pictures like scanning and all. So it's a very challenging process. Yeah.
Absolutely.
There is a fourth question I can see regarding the migrant health workforce. That's indeed increasing, but migrant health workforce at crucial positions, and I totally agree with that. Where changes in care provision can be achieved, the chances are rather limited. And how do we get them more involved in the governance of healthcare? From our project right now in Norway and the Netherlands, it looks like, perhaps more in Norway than the Netherlands, that there is a dearth of immigrants in leadership position, also at the intermediate leadership levels. So I think, well, in my opinion, it's one important task is really to recruit more immigrants into leading positions. But I mean also regarding cultural and migration sensitivity, there should be more open debates when planning for the care services of how immigrants could also contribute more to how our systems are working. Thinking that, for example, the concept of inclusiveness means also changing the whole system. So there we create space for more creativity and for also more innovation, where people with other cultural backgrounds could play a part. So that's the first answer to that question. I don't know whether you, Kathy, would like to add something.
Yes, please, Frode, because I would like to mention one crucial point, that is, when we say migrants, migrants are heterogeneous, right? You can't put all in one box, one black box. so it is important that even though there are migrant workers, not all are the same. There are different cultures, different religions, and different attitudes, and so on. So it's important that migrant workers also take this education in culturally sensitive care.
Yeah, absolutely.
Yeah, absolutely. Thank you both. Sorry, just to barge in there, but pretty much out of time now. I was just wary looking at the clock there, but unfortunately, obviously, we only have an hour. But it's been some really interesting discussion so far, and it's a shame that we can't carry on for longer, of course. But of course, but just before we round things off, I just do want to refer back to what I mentioned at the beginning of the session. So the working group on mental health that I know, I think Frode yourself, you coordinate that, don't you? As part of the European Forum for Primary Care and our primary care multi-professional researcher network. So of course, if anyone wants to get involved, please let us know. The email address there. Of course, you can also email me directly if you have any interest, and also via our website as well. So finally, though, I would like to extend again my thanks to Kathy and Frode for today's presentations. Really great stuff and really interesting discussion afterwards. We will upload the recording as well for you all, and also on our YouTube channel as well. So that's available for everyone. So finally, everyone, enjoy your weekend, and thanks very much for attending today. Goodbye.
Thank you.
Thank you very much.
Bye. Thank you.
Bye-bye.
Bye.